This program is brought to you by Community Trust Bank, Medical City, Bid Select, and the Neely School of Business at TCU. Welcome to Platforms, the life-lifting news program for women. Now, here's your host, Siobhan Palmer.
Hey, welcome everybody to Platforms, the life-lifting news program for women. This week we're at Medical City, Dallas, and we're talking about minimally invasive surgeries. We're talking to some of the top specialists at Medical City, and our first guest today, we're absolutely delighted to have him. Dr. Todd Dewey is a cardiothoracic and transplantation surgeon. He's director of the Circulatory Assist Device Program here at Medical City, Dallas. Dr. Dewey is board certified in thoracic surgery, and he has completed specialty training in cardiac transplantation and ventricular assist devices at Columbia-Presbyterian Medical Center in New York, to name a few things. Dr. Dewey, welcome to the program.
Thank you, Siobhan. It's good to be here.
I'm delighted because we'll really be able to get in depth about your specialization, and hopefully you'll talk to us in layman's terms. I'm the board certified layman here. So let's start at the beginning here. I know that define the term thoracic, because unfortunately I think a lot of people don't even know what that means.
Well, thoracic just is basically a word that means chest. It's sort of a designation on where our area of specialty is. Surgery has become sort of segmented over time. People have developed niche specialists. Back in the old days, general surgeons were really that. They were general surgeons. They delivered babies, they pinned hips, they did orthopedic surgery, they did chest surgery. But as medicine has evolved and the fund of knowledge has increased, it became really apparent that you can't be good at all things, and so we tend to specialize in certain areas. And so for thoracic surgery, is basically anything between the diaphragm and the chin is sort of our area especially. So it's the heart and the lungs, the esophagus, the mediastinum, the thymus, the glands, all those things are sort of the area of the thoracic surgeon.
Great. Okay, now the theme of the show here is minimally invasive surgery. So how does that pertain to your area of specialization? Because I think when most people think a heart transplant doctor, the last thing you would be doing is minimally invasive surgery.
Right, and that's true. I mean, even now today, heart transplantation is still sort of done the same way it was done by Shumway back at Stanford back in the late 70s. We still have to fully open the chest and use the heart-lung machine.
Okay, you mentioned Shumway. Who's this?
Norman Shumway is the father of cardiac transplantation in the United States. He was the guy who really pioneered the field working out of Stanford back in the late 70s. So because we take the whole heart out, we have to make a reasonable size incision so that we can sew the new heart in. So cardiac transplantation really hasn't gotten much more minimally invasive than it was back in the 70s. But our goal really is with surgery is to maintain the same quality and the same outcomes that we have, but do it in a less invasive way so that it shortens the patient's recovery time, decreases their hospitalization, and decreases the amount of discomfort that they have. And so that's kind of where we've gone. And so it can mean anywhere from not using the heart-lung machine to do certain operations performed on the outside of the heart, or even using small incisions but working on the inside of the heart, but not making as big an incision, not dividing the breastbone, that sort of thing. Okay.
Why don't we go through just the various procedures you and your team do in this field as it relates to minimally invasive?
Sure. Well, really the number one thing and the hottest thing going on right now is minimally invasive aortic valve replacement. And we've been fortunate. We were the third center in the United States to embark upon this program, and we're actually the first center to do a certain type of this procedure where we go right between the ribs and make a very small incision and are able to replace the aortic valve without stopping the heart or using the heart-lung machine or opening the chest. And it's really revolutionary technology in such that the valve itself is like a stent, like a coronary stent, with leaflets sewn in it. And so it's mounted on a balloon like a catheter, and we can either thread it up through the leg and replace the valve that way, or go through a very small incision in the chest. Why that's important is because aortic stenosis is the most common valve problem in the United States.
What does stenosis mean?
It means narrowing. Normally the opening of the aortic valve should be about the size of a $50. Most people who have aortic stenosis, the opening is down to the size of a nickel or a dime. And what that does is it puts pressure on the heart, causes symptoms of shortness of breath, congestive heart failure, and it's the most common abnormality we see, and it's the most common valvular problem with aging. We have an aging population in the United States. In the next 20 years, 1 out of 5 people in the United States will be over the age of 65. And that's the most common age group to have aortic stenosis. And so what we've not only seen here, but also nationwide in cardiac surgery is the fact that patients are getting older. We're seeing more and more valve issues, particularly aortic stenosis, coming up. And there's a group of people, women being one of them, who are at higher risk for cardiac surgery. And it's been known for a lot of years that women have worse outcomes with cardiac surgery than men.
Now, why is that?
A lot of it is due to the fact that particularly with bypass surgery, their arteries are smaller. Smaller arteries are harder to sew. It's harder to keep them patent. They tend to be smaller people, and that smaller body size makes it a little bit more traumatic for them to undergo cardiac surgery. And we know, as we get older, the women tend to outlive the men die off. And so a lot of the people we see now who are not candidates for conventional valve replacement, probably 2 out of 3 are women.
Are female, okay.
Are women. And so this is kind of what this technology is designed for, people currently who either can't have surgery at all or at such high risk for surgery that the risk is prohibitive. And so we're involved in a study called the PARTNER trial, which is it's sponsored by the FDA, and it's the trial of this revolutionary valve towards commercialization. And so the trial concluded last August of 2009, and there's a 1-year follow-up, and so it'll go before the FDA panel sometime this fall. And hopefully this valve will be commercially available to us in the United States sometime next year. It's already commercially available in Europe starting in 2007, and they've seen a 40 times increase in the utilization of this valve over that time. And so people are not having conventional open heart surgery with a sternotomy and bypass. More and more patients in Europe now are being treated with this catheter valve. The procedures can be done in 30 to 40 minutes. They can be home in 2 or 3 days, and the recovery time is very short.
Dr. Dewey, what is the typical recovery time if you do open up a patient, a conventional type surgery on hard vise, doing this minimally invasive?
A lot of the times it depends on the patient. By and large, say for an aortic valve replacement, the hospital stay is 5 to 7 days, and probably 6 to 8 weeks to recover. Generally speaking, if all we're doing is replacing the aortic valve, we don't open the full breastbone anymore. We just open the upper 1/3 of the breastbone and make a much smaller incision, and we can still do the operations that we need to do, provided they don't have coronary disease or something else that we have to get to, which we can't see through the small incision. So, our whole goal here, particularly at Medical City, is, as least invasive as possible to get the job done. We want to try and repair versus replace when we start operating on the valves. If we can repair the patient's own valve, we do that preferentially rather than replace it with an artificial valve. And I think we've had very good success with that.
And how do you determine who are candidates for this type of procedure?
Well, yeah, that's a good question. A lot of it depends on 2 things, really. It depends on what procedure they need and whether there's a minimally invasive way that we can perform the procedure, such as transplant. There's just no way we can take a whole heart out and put a whole heart in through a very small incision. We have to have sufficient access to do it. But if they have a procedure that's amenable to a minimally invasive approach, and then if their body habitus or the way they're built makes it possible, then we tend to go that route. If if they weigh 350 pounds, it's very hard to operate through a very small incision because you have to go through 5 or 6 inches of fat just to get to the chest. And so those patients typically get conventional type approaches. But smaller people with normal body sizes, if we can do the procedure through a small incision, that's how we do it.
That's great. Dr. Dewey, hold that thought. We've got to go to break. But when we come back, ladies and gentlemen, we'll continue our conversation with Dr. Todd Dewey, a cardiac surgeon here at Medical City Dallas. This is Siobhan Palmer with Platforms.